بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. This is Al-Walid Ali Ahmed Al-Hassan again with the second part of the acid-base disorders talk. And today we're going to try to cover areas of treatment and give some illustrative cases. So let's talk about metabolic acidosis first. And why is it harmful? Why could it be harmful? Why should we care about treating acidosis and acidemia? Well, there are multiple adverse consequences of severe acidemia. For example, in the heart, it can lead to problems with contractility of the heart, vasodilatation, pulmonary vasoconstriction, sensitization to arrhythmias, depressed responsiveness to pressors, like, for example, somebody who is in the ICU who's requiring pressor support to get their blood pressure up. The fact that they're acidemic makes it less likely that they will respond well to the pressors. Obviously, hyperventilation, because that's a primary compensatory way by which the body tries to correct the acidemia, metabolic acidemia. That can lead to muscle fatigue, dyspnea, and also there are metabolic consequences that has to do with insulin resistance, problems with anaerobic glycolysis, protein degradation, decreased ATP synthesis, hyperkalemia, and on the long term, people who are chronically acidotic can develop nephrocalcinosis, because basically the body is going to try to buffer the acid from bone, and that mobilizes calcium from bone. So if you have relative hypercalcemia, that's going to lead to hypercalciuria, and then nephrocalcinosis, and potentially worsening chronic kidney disease as well. So there are multiple consequences of severe acidemia. So how should we treat it? Well, first of all, we should try to treat the underlying pathophysiologic process. For example, lactic acidosis, one of the most common causes of acidosis, usually happens as a consequence of hypoperfusion. So we try to restore perfusion by adequately resuscitating patients. So if a patient is diabetic ketoacidosis, you're going to try to treat diabetic ketoacidosis by giving insulin fluids, etc. Now, for acute metabolic acidosis, that usually happens in the setting of acute kidney injury, not yet requiring kidney replacement therapy or dialysis, you could try sodium bicarbonate infusion. Remember that sodium bicarbonate comes in ampoules. The ampoule has 50 millimoles and 50 mils. So in certain situations, you can give the whole, for example, code status where somebody is not, the heart is not pumping, they're severely acidemic. You can give IV sodium bicarbonate directly IV. And in people who have or acute kidney injury with acidosis pH less than 7.2, 7.1, you can actually try to calculate their bicarbonate deficit and then give the deficit. And usually we try to do that over a course of 48 hours or 32 hours, 36 hours. You don't try to correct right away quickly for reasons that we're going to talk about later on. So usually the serum bicarb goal is 20 to 22. pH more than 7.2 or 7.3. Above that is physiologic, so you don't really want to overcorrect to like 7.4 or something like that. Just getting the pH, like 7.2 higher or 7.3 and higher, that should be sufficient for the body. Now, for chronic metabolic acidosis, for example, people who have renal tubular acidosis or chronic kidney disease, you can use sodium or potassium salts of either bicarbonate or citrate, because citrate is metabolized in the liver to yield bicarbonate. So how do we give sodium bicarbonate? As I said, you can give an ampoule directly in the vein, but that's usually only needed in like code situations, because that's very hypertonic solution. Okay, each ampoule has 50 millimoles and 50 mils. This concentration supplies 84 milligram per mil of 1 millimole per mil of each sodium bicarbonate. So if you do a little math here, you're going to find out that the ampoule, which has 50 millimoles contained in 50 millimoles of sodium bicarbonate contained in 50 mils, which would correspond to 50 millimoles of sodium and 50 mol of bicarbonate. That's going to be a total of 100 millimoles per 50 ml. So each ampoule has 100 millimoles, because remember, you count both are osmotically active. So you have 100 of this, 100 millimoles per 50 mils, which gives a concentration, usually referred to the concentration in liters. All right. So that's going to, if you take 1 liter, which is 1,000 mils, it's going to contain 2,000 milliosmol per liter. So compare that to the osmolarity of the serum, which is 280, 290 milliosmol per liter. This fluid is like 8-9 times more hyperosmolar, negative, so relative to the plasma. So just keep that in mind. It's very hyperosmolar, and therefore we only use it in a cold situation where pH is very low, the patient is very sick. That's when you give IV sodium bicarbonate directly. But most of the time we give isotonic bicarbonate. And how do we make an isotonic bicarbonate infusion? Just by combining 3 ampoules, put it in a liter of D5, okay, or a liter of just sterile water. The pharmacy can do that. And it's an isotonic solution because it's going to have 150 millimoles in 1 liter. Okay, that's pretty close to normal saline, which is 154 millimole per liter. So that's isotonic bicarbonate solution, and this is the one that we usually do. We usually use for patients to replenish bicarbonate because it's isotonic. There's no risk of hyperosmolar fluid that can raise the serum sodium and cause hypocalcemia, hypokalemia. All right, so how much to give? Again, you want to attain a pH of 7.2 or maximum 7.3, and that may require only raising the bicarb to 10 to 12 millimole per liter. All right, now, milliequivalent and millimole per liter is similar because bicarb is unimolar. Okay, so how do we calculate the deficit? Well, the bicarbonate deficit is equal to the bicarb space multiplied by the bicarb deficit. For example, if a patient serum bicarbonate is 10 and you want to take it up to 12, that's 2 liter deficit 2 millimole deficit. You want to take it from 10 millimole per liter to 12 millimole per liter. The deficit is 2 millimole per liter, and the 2 millimole per liter is going to be multiplied by the space in which bicarbonate is present. And the space is usually just the total body water, because bicarb is present in the total body water, all right, which is 60% in males and 50% of the weight in females. Well, we have to keep in mind that the bicarb space increases as the serum bicarb decreases further. Like with severe acidemia, the bicarb space is usually like, can be estimated to be like total body weight. So instead of multiply by half of the body weight, you may have to multiply by 70 or 80% of the body weight. So that will give you the bicarb deficit. So once you have the deficit and you have your isotonic fluid, which has 150 millimole per liter, then you can determine how many liters you want to give to your patient. All right, now that was about IV bicarbonate. What about oral bicarbonate? Well, as I said, there are multiple options. Some, containing potassium, others containing sodium as the anion, as the cation. And anion itself is either bicarb or citrate. As I said, citrate is metabolized in the liver to yield bicarbonate. So there are multiple options, okay? And here are the, how many, what is the amount of bicarb that is present on each of these ones. Sudan you may not have access to all of these, but at least sodium bicarbonate is the one that is mostly used, and this is the tablets of sodium bicarbonate. Each tablet has 650 milligrams, which is equal to 7.7 millimole of sodium and 7.7 millimole of bicarbonate. All right, so if you could use that in order to calculate the deficit and see how many tablets you want to give to your patient. And sometimes, our chronic kidney disease patients, we give them just like a twice, per day, 1 tablet twice per day, or 2 tablets twice per day, or 3, according to the target of the serum bicarb that we're going to be shooting for. Now, if the tablets are not available, then you could simply use sodium bicarbonate, which is كربونات الصوديوم اللي هي يعني تستعمل في الطبخ، يعني هي موجودة ومتاحة حتى يعني بصورة أيسر قد تكون من الحبوب. Easier might be than the tablets, and it will actually have the 1/2 teaspoonful has 2.4 grams, and that contains about 29 millimole of sodium and 29 millimole of bicarbonate. All right, so it's actually much higher. If you don't have the tablets, you could just use the powder and ask your patient to take, like, for example, 1/2 teaspoonful twice a day, and that will easily give him about 60 millimoles of bicarbonate every day. So that's an easy option to use if the tablets are not available. Potassium citrate sometimes is used in people with renal tubular acidosis who have concurrent hypokalemia and acidosis. So by giving potassium, you address the hypokalemic part, and citrate again is metabolized in the liver to yield bicarbonate. Now, chronic metabolic acidosis is one of the complications of chronic kidney disease. As GFR declines, the serum bicarb drops because the kidney is unable to generate bicarbonate to satisfy the daily acid load, as we explained in the previous talk. So people with chronic kidney disease need, bicarbonate, because there is some evidence that, uncorrected acidosis can speed up the deterioration of chronic kidney disease. So the previous guidelines, which were issued in 2012, suggested that, the serum bicarb should be kept above 22. So if it's less than 22, you should give your patient bicarbonate. However, I should point out that studies which looked at this target did not really found a meaningful difference in the outcomes of the patients, and therefore the newer guidelines, which came out 2024, suggested using bicarbonate only if the bicarb drops below 18 millimoles per liter in adults. So they, as you notice, they dropped down the threshold from less than 22 to less than 18, and and you should really monitor your patient to make sure about other things such as potassium and fluid status. All right, so let's go through this case. Hopefully, it will clarify some of these things. Here is a 29-year-old man who has been hospitalized in the psychiatry service for 2 months because of depression. He leaves the hospital on a pass, so he goes out of the hospital, and then he comes back complaining of abdominal pain and vomiting. Over the next several hours, he becomes more agitated, and then he was found in an unarousable state, and he was posturing. Okay. All right, so he's febrile, he's tachycardic, and he's tachypneic, blood pressure a bit on the high side. He's unresponsive to pain. Fundoscopic findings are within normal limits, and there's no odor noted on his breath. So let's look at his labs here. His sodium is 142, potassium 4.7, chloride 111. Total CO2, which is serum bicarbonate, dissolved serum bicarbonate, is 10 millimole per liter. So obviously that's low. So all of these numbers so far are okay. Maybe chloride is a bit high. Carbon dioxide, total CO2, which is serum bicarbonate, usually is like 20, 23, 24. Here is 10. So that indicates the bicarb is low. Calcium is normal. Blood urea and nitrogen and creatinine may be slightly higher. The ABG or room air, he has a pH of 7.2. So this is acidemia. PCO2 is 24. So that's low. And PO2 of 100%. Okay. So what is this patient's acid-base disturbance, and what are the possible causes? So obviously you want to start with the pH, arterial pH. It's 7.2, so he has acidosis, or it's actually acidemia because it falls lower than the normal range for pH. So he has acidemia. So what is we look at the bicarb in the serum and the bicarb in the ABG. So if acidosis, so you'd expect the PCO2 to be high, but it's actually low. So this is not respiratory acidosis. You'd expect the bicarb to be low, so this is metabolic acidosis. All right, so this is metabolic acidosis with some respiratory compensation. So that's number one. Number two, what kind of metabolic? Whenever you see metabolic acidosis, you want to see if it's a high anion gap or a normal anion gap, and for that you calculate the anion gap. So what is anion gap here? So 142 minus 111 plus 100 plus 10, so that's 121. So 21, 31, 41, 21, 31, 41, that's 21. The anion gap is 21. The normal anion gap is 10 to 12. So this is a high anion gap metabolic acidosis. Okay. So again, the combination of the low PCO2 and the low bicarbonate confirms it's a metabolic acidosis. All right. Number two, the anion gap is elevated. Again, it's 21. So the most likely cause of metabolic acidosis with an increased anion gap, there are multiple things, as I said, as I gave you the mnemonic before. It includes DKA, lactic acidosis, ketosis like from starvation or alcoholic ketoacidosis, salicylates, overdose, toxic alcohols such as methanol, ethylene glycol, and kidney failure. All right. So now, the third question when you encounter somebody, first of all, you look at the pH, you determine what is the primary disorder. Second of all, you see if it's metabolic, you calculate the anion gap. Here it's an anion gap metabolic acidosis. Third is look at compensation. Is he really compensating well? So obviously he's tachypnic, and this is the reason why he's tachypnic is that he's trying to compensate. But is the compensation appropriate? If the patient is not tachypnic, the pH should be even lower, and this would suggest an additional respiratory disorder. All right, this patient is showing an appropriate respiratory compensatory response. Okay, so okay, remember, you can determine if the constant compensation is adequate or not by looking at using the Winter's formula or just adding 15 to the bicarb. So 15 plus 10 is 25. 25 plus or minus 2, that's what the PCO2 be. The PCO2 is 24, which is pretty close to 25, which tells us that he's adequately compensating. So there's an adequate respiratory compensation. If the PCO2 is higher than 24, for example, 30 or 35, then he's not adequately compensating. And there is a mixed disorder. There is another disorder, which is respiratory acidosis. All right, so this patient is appropriately compensating. Okay, so now a patient with high anion gap metabolic acidosis with adequate respiratory compensation, right? So now our job is to figure out what is the reason for the metabolic acidosis. So to know that, there are some other tests because we have a differential diagnosis. As I said, we have lactic acidosis, diabetic ketoacidosis, alcoholic ketoacidosis, starvation, toxic alcohol ingestion. So these are the reasons, and therefore we have to do some other laboratory tests in order to figure out what's the cause. So again, we answered the question number 2 already. So now, what other tests would be useful to find out what's the cause of his metabolic acidosis? So initial tests might tell us, right, what is the cause of this process. And those, first of all, is the serum glucose, because if hyperglycemia is present, then we look at the serum ketones to ascertain if acetoacetate is present. All right, the serum ketone level is going to tell us if the patient has diabetic ketoacidosis. Number 2 is ingestions like salicylates, lactate levels. Those can be tested, but if you do not have a facility to do that, lactate is a lot of labs are do it, but salicylates is kind of difficult. because sometimes it's send out. This will take time to come back. All right. So another simple test to do is serum osmolality. All right. As I pointed out in the previous talk, the serum osmolality can give you a hint if there is an osmolar gap. If there is an osmolar gap. Remember, we said the osmolar gap is the difference between the measured and calculated osmolality, and it should be 10 or less. If it's higher than that, then there is a toxic substance that is accumulating in the body. In this serum, in this patient, the serum glucose was normal and no serum ketones were detected, so that rules out DKA. Okay. The plasma osmolality in this patient was 347. All right, 347. So if you compare that to the serum osmolality, which can be calculated by multiplying 2 times 142 plus glucose and blood urea nitrogen. All right. The blood urea nitrogen has to be divided by the molecular weight in order to convert it to millimoles per liter, because you want to unify the units. And glucose, which was normal about 5 millimoles per liter. So there was an osmolar gap of about 51, right? So there is a high osmolar gap. So this osmolar gap, what does it mean? With this new information, what things should come to mind? Well, with this, you know that the patient has metabolic acidosis with an increased anion gap as well as an osmolar gap. All right, so this limits the possible diagnosis to either methanol or ethylene glycol ingestion. All right, so how would you proceed to determine which substance is responsible for the patient presentation? Okay. So to determine which substance is responsible for the patient's presentation, both methanol and ethylene glycol should be assayed in the blood if possible. All right. So remember, methanol, it comes sometimes from badly done ethanol. All alcohol is badly done. It should not be. We're not talking here about drinking alcohol. But what I'm saying is, alcohol that is done was prepared, which is ethanol, which is prepared in not a good situation. Like, for example, just like local, alcohol traders who make alcohol, it can be adulterated or mixed with methanol, which is toxic. It should be just pure ethanol. If it has a lot of methanol on it, then that can cause a high anion gap and high osmolar gap as well. And in this situation, remember, methanol is toxic to the eye, so you can have retinal problems. This patient did not have retinal issues. Other things that can help you determine methanol or ethylene glycol. And by the way, ethylene glycol is something that is used in the West in the cars. It's called an antifreeze, which is they put it in the car, the radiator of the car, in order to prevent icing and formation of ice inside the radiator. All right, in the winter time. So some people can drink it as a way or a means for committing suicide. Okay, and that can lead to high anion gap and high osmolar gap metabolic acidosis. And so basically, what you want to do is to try to differentiate between both of them. Things that can help you differentiate is, methanol can have retinal toxicity. Ethylene glycol can have some oxalate crystals in the urine. So if you see them under the microscope, that's more consistent with ethylene glycol. How do we treat them? There is a drug that is called fomepizole, which is an alcohol dehydrogenase inhibitor, which prevents metabolism of these toxic alcohols to their toxic metabolites. So the alcohol itself may not be as harmful as its metabolites, and this drug can stop that. It's called fomepizole. Anyway, so the point of this case is to go through the systematic way of acid-base analysis and see if compensation is appropriate and how to go about determining the cause of a high anion gap metabolic acidosis. Okay, let's look at this other patient here. This is a 79-year-old female, old woman with a COPD, diabetes, chronic kidney disease stage 3, which means that the GFR is somewhere between 30 and 60 mils per minute. Admitted to the ICU 2 days ago with severe sepsis and urinary tract infection, and she was found to be profoundly hypotensive, but blood pressure improved with IV fluid resuscitation. She was given IV fluid resuscitation. She received 2 liters of normal saline in the emergency department and other 4 liters in the ICU, so a total of 6 liters. All right, blood pressure a bit on the low side. She's intubated, sedated. Oxygen saturation is 96% on 30% FiO2. PEEP of 5, respirations 20. Lung volume 300 mils, the lungs are clear, there's no edema. She's still receiving normal saline at 100 mils per hour because her blood pressure is still on the low side. So these are labs which are obtained 2 days after admission. Normal sodium 142, potassium 3.5, a bit on the low side, chloride a bit on the high side, 113. Bicarbonate is 17, so clearly this is acidosis because serum bicarbonate. By the way, total CO2 is bicarbonate plus dissolved CO2, and it just reflects the serum bicarbonate. The normal being 23, 24, 25. So this is low, which indicates high metabolic acidosis. BUN 18, creatinine 1.4, both a bit on the high side, albumin 3.6, a bit on the low side, calcium is normal. So this is her pH is 7.32. And here are the PCO2 and the PO2. All right, so question is, what is the most appropriate way to manage her acidosis? Obviously, this is acidosis, number one. Whenever you find metabolic acidosis, again, this is metabolic acidosis because the numbers are suggestive of that. You look at the align gap, 142 minus 113 plus 17. 113 plus 17 is 123, 130. So 113 plus 10 is 123, plus 7 is 130. So the anion gap is 12, which is normal. So this is normal anion gap metabolic acidosis. So what is the reason for the normal anion gap metabolic acidosis for this patient? What is the reason for that? And this is a question that you have to answer in your mind before you answer this question, which is how to manage this acidosis. Should we increase the rate of normal saline? Should you check the serum lactate and ketones? Should we increase the respiratory rate on the ventilator? Should you change the IV fluids to ringer lactate instead, or should you infuse 2 ampoules of sodium bicarbonate? So, well, first of all, this is mild metabolic acidosis. The most appropriate strategy for this patient is to change the IV fluids to a more balanced solution, such as ringer lactate, which is option number D. Right, so this patient has a non-anion gap metabolic acidosis, and because she has received a large volume of normal saline for volume resuscitation. So the chloride concentration in normal saline, again, is 154 millimole per liter, which is higher than our chloride, which is about 105 millimole per liter. So that's significantly higher than which the normal serum bicarbonate is. So the administration of large volume of normal saline can cause hyperchloremia. All right, and that's going to dilute the bicarbonate. So this scenario has been called a dilutional acidosis. And then usually it's usually mild, okay? So if IV fluids are no longer required and kidney function is adequate, the patients with this profile can excrete the excess chloride and generate new bicarbonate to correct the mild defect without any additional intervention. However, here, since hypotension persists, additional fluid may be required. So the generation of a metabolic acidosis in this case can be explained through consideration of bicarbonate-centered approach that uses the Henderson-Hasselbalch equation. All right, well, where you remember the Henderson-Hasselbalch equation is acidity pH is proportionate to A, B, which is bicarbonate, divided by CD, which is carbon dioxide. All right. So now, given this relationship, dilution of the bicarbonate, which is on the numerator, dilution of the bicarb after infusion of large volume of bicarbonate-free IV fluids, while the PCO2 remains unchanged, would mandate a decline in pH. All right. So basically, what needs to happen here is if you need to continue giving fluids for this patient with mild metabolic acidosis because of the hyperchloremia, the chloride in the normal setting, then it's best to use a balanced solution like Ringer lactate, which has way lower chloride. That's 109 millimole per liter. Okay, so that will help correcting this mild acidosis, which is called dilutional acidosis for this patient. Okay, so now we're going to talk about metabolic alkalosis, which is a disorder that results from gain of excess bicarbonate, either exogenous or endogenous, or both. And I want to remind you again of the Henderson-Hasselbalch equation, which relates the pH to the bicarb and CO2. So the pH is equal to, that's regarding the bicarbonate system. The pH is equal to a constant plus base, which is bicarbonate, divided by carbon dioxide. A equals B base divided by carbon dioxide CD. So this is a disorder that results in gain of bicarbonate. So if the bicarb goes up, هي موجودة في البسط in the numerator, then the pH is going to go up. So that's going to be metabolic alkalosis. All right. And the body is going to try to compensate by increasing the carbon dioxide up so that so this can, compensate for the increase in bicarbonate. And this is a compensation for metabolic alkalosis is by retaining carbon dioxide, which is hypoventilation. So what is metabolic alkalosis? It's a gain of bicarbonate either endogenously from our body or from exogenously. It is the most common acid-base disorder in critically ill patients in the ICU, especially those on the ventilator and receiving, bicarbonate. So usually we think of metabolic alkalosis in two phases: generation phase when it starts, and then maintenance phase when it continues to stay on. So usually what starts or generates bicarbonate in patients is either loss of hydrochloric acid, such as vomiting. All right. So when you lose vomitus, it has an acid on the stomach. So you're going to stay with bicarbonate excess inside. So that starts it. Vomiting starts GI causes of metabolic alkalosis, or NG suction, or if you have chloride-rich diarrhea. Whereas renal endogenous gain of base can happen from excessive generation of bicarbonate through enhanced hydrogen secretion. For example, hyperaldosterone. Remember in the first talk we said aldosterone enhances bicarbonate generation because aldosterone works on the epithelial sodium channel, getting sodium in. So for each sodium going in, there will be a negative charge in the lumen, and that enhances potassium and hydrogen secretion. So for each hydrogen secretion, there is a bicarb that is gained. So if you have hyperaldostate, like hyperaldosteronism, that's going to lead to increased distal sodium absorption, volume expansion, and alkalosis and hypokalemia. Diuretics and diuretic-like syndromes, for example, if your patient takes a lot of diuretics, or they have a diuretic-like syndrome like Bartter and Gittelman syndrome, where there is an active activation of the channels which are blocked by, there's a defect on the channels which are blocked by loop diuretics and thiazide diuretics, that can lead to a state of relative hypovolemia and secondary hyperaldosteronism, and more importantly, distal sodium delivery. So diuretics going to block sodium absorption proximally. That's going to deliver more sodium distally, so more sodium available for the epithelial sodium channel to get the sodium in, and potassium and hydrogen is going to go out. For each hydrogen that goes out, remember there is a bicarb that is gained. So that leads to renal excessive generation of bicarbonate. All right, or generous delivery of sodium salts to the distal tubule. Again, this is about sodium delivery. But now sodium is not delivered with bicarbonate like before, but also with things like, for example, some drugs like penicillin, piperacillin, tazobactam. These are salts, sodium salts. So as they're excreted in the kidney, they're going to bring more sodium distally, where sodium is going to be absorbed, potassium and hydrogen will be excreted. Shifting, for example, with hypokalemia, if you have hypokalemia, potassium is going to shift out of the cells to replenish the outside potassium, and then hydrogen is going to shift intracellularly and that will enhance ammoniogenesis. Remember, ammonia is a main mechanism by which the kidney is able to enhance hydrogen secretion, and hydrogen secretion means bicarbonate gain. So that's again another cause of endogenous gain of base. Whereas exogenous gain is like if you're taking sodium bicarbonate or sodium bicarbonate precursors such as acetate or citrate or gluconate. So now that was the generation phase. So that was the starts it, right? So now if the kidney is healthy, it's doing its job, and the patient develops alkalosis, in which there is excess bicarbonate, the kidney should excrete that excess bicarbonate. If the kidney fails to excrete that excess bicarbonate, that's going to lead to maintenance, what we call istimrariyat al-alkalosis, because now the kidney is failing to excrete the bicarbonate, and that usually happens because of hypovolemia. So, for example, a patient who's vomiting, in the end, they're going to become hypovolemic. So when the patient is hypovolemic, then they have decreased effective circulating volume, that's effective arterial blood volume, which, along with potassium depletion, will lead to enhanced proximal bicarbonate reclamation. Also, that's going to lead to aldosterone RAS system activation, renin-angiotensin-aldosterone system activation, and that aldosterone is going to increase sodium absorption distally. For each sodium that goes in, there are potassium and hydrogen that goes out. So the hydrogen goes out, meaning a bicarb that is gained. Okay. Number 3, an important mechanism is also chloride depletion. Remember, chloride and bicarbonate are both anions. So if the bicarb, if the chloride is depleted, the bicarb has to go up. Okay. And there is a channel that is called the beta intercalated cell in the distal tubule that pushes chloride in and drives bicarbonate out. So if there is chloride depletion, there would be no bicarbonate being secreted in the distally. So that's going to be retained, and you're going to end up with maintenance of the alkalosis. And finally, reduction in the GFR leads to decreased bicarbonate filtration. So let's try to explain this graphically. This is a proximal tubular cells where they have a sodium hydrogen exchanger, and the proximal tubular is where ammonia is generated. And then you have distal tubule that has a principal cell and the beta intercalated cell, which I just talked about. It has a channel which is called pendrin that pushes chloride in and bicarbonate out. So then what happens here? If your patient becomes hypovolemic, then the RAS system is activated. So angiotensin 2 is going to work to enhance sodium absorption proximally, and more sodium absorption proximally means more hydrogen secretion. Hydrogen is equal to bicarb gain. So that's a mechanism of metabolic alkalosis maintenance. Number 2, hypokalemia. As I pointed out on the first talk, hypokalemia enhances ammonia generation. All right, so we're going to have enhanced ammonia generation. When we have more ammonia is a thing that traps hydrogen. So you're going to trap more hydrogen, right? So more hydrogen is going to be excreted, and for each hydrogen that is excreted, there is a bicarbonate that is gained, because hydrogen and bicarb come from carbonic acid. So if you lose hydrogen, you gain bicarbonate. So hypokalemia is an important mechanism in maintenance of metabolic alkalosis. Now, low chloride, as I said, you have less chloride, so you cannot reabsorb chloride, then you cannot excrete bicarbonate. Bicarbonate is going to be retained. All right. And finally, hyperaldosteronism, you're going to enhance epithelium sodium channel work. So sodium is going to go in. That's going to create a negative charge on the lumen here. So that's going to enhance potassium secretion and hydrogen secretion. So hydrogen secretion. There is another pump here that is called the sodium hydrogen. The potassium hydrogen exchanger on the alpha intercalated cell. So for each hydrogen that is excreted, there is a bicarb that is gained. So all of these contribute to maintenance of metabolic alkalosis. So whenever I see somebody with metabolic alkalosis, I ask myself, what should the kidney be doing? if you have excess bicarbonate? Well, the appropriate response, obviously, is to excrete the bicarbonate and reabsorb chloride instead. So therefore, the urine chloride should be very low. It should be less than 10 if the kidney is doing the right thing. However, the inappropriate response is to keep retaining bicarbonate and excreting chloride, and then the urine chloride is going to be more than 20 millimoles per liter. Okay, so now let's take this into consideration when we talk about how to approach primary metabolic alkalosis in general. So there are two, basically, classes. The first one is a patient who is volume depleted, for example, from severe vomiting or excessive intake of diuretics. They're going to have secondary hyperaldosteronism. The RAS system is going to be activated because of the volume depletion. So if you find the urine chloride is low, then it's vomiting, suctioning on the NG tube, low chloride intake, or later on with diuretics. If you have a high urine chloride, so that's active diuretics which are being administered at the time, or these two syndromes are like taking diuretics, because Bartter and Gittelman syndrome are the inhibitory defects of the channels which are blocked by the diuretics. So that's like what you're taking, to just take diuretics constantly. Whereas if your patient is volume expanded, so there is primary hyperaldosteronism. All right, so primary hyperaldosteronism, the urine chloride is going to be high. All right, and in these situations, you're going to look at plasma renin activity. If it's high, then renal artery stenosis or renal secreting tumor. But if it's low, then this is an adenoma or adrenal hyperplasia. So what are the complications of metabolic alkalosis? Why should we care about metabolic alkalosis? For example, somebody in the ICU whose pH is 7.5, who cares? Well, because studies have shown that alkalosis is associated with a higher morbidity and mortality and longer ICU stay. Obviously, if you have alkalosis, then you're going to have hypocalcemia because the albumin is going to be free. There's no hydrogen enough on the albumin to bind the albumin, so it's going to bind calcium. So therefore, your ionized calcium is going to drop. So this is one of the major complications of metabolic alkalosis is hypocalcemia. Hypokalemia is also a consequence of alkalosis because of multiple reasons, which I've talked about. One of them is a bicarb that is being excreted. It's going to take potassium along with it, okay? And the shifting that happens, if you have low hydrogen in the extracellular fluid compartment, then potassium is going to go in, and hydrogen is going to try to come from the cells to the extracellular fluid compartment to replenish the lost hydrogen. So obviously, the body is going to try to compensate by suppressing ventilation. That's going to lead to high PCO2, okay? And that may affect oxygenation. It's also going to shift the oxygen dissociation curve to the left, and that leads to less oxygen release at the tissues. And that might be the reason for cardiac arrhythmias, which may also be due to the accompanying hypokalemia and hypomagnesemia. So how do we treat metabolic alkalosis? It depends on the underlying etiology. For example, somebody who's NG suctioning or excessive diuretics, you want to cut down on the dose, or stop the NG suctioning, or treat the vomiting if they're vomiting. What pH should we be shooting for? Well, this is not established, but less than 7.55 is probably reasonable. Less than 7.5 even is probably better. You want to treat hypokalemia aggressively because it contributes to the maintenance of the of the metabolic alkalosis, and you want to replete with chloride whenever necessary. As I said, hypochloremia or low chloride has an important role in the pathogenesis and maintenance of alkalosis. You want to replace chloride if needed. Acetazolamide is a proximal tubule diuretic that blocks the carbonic anhydrase, which is responsible for reabsorbing the bicarbonate. So if you block that enzyme, you're going to enhance bicarbonate secretion. So therefore, acetazolamide is a good diuretic that can help here, especially if ongoing diuresis is necessary. For example, somebody who's Lasix, they become alkalemic, but you want to keep diuresing them because they're still having pulmonary edema. You can add acetazolamide, and that can correct like a state of proximal renal tubular acidosis and can help correct alkalosis. hydrochloric acid infusion is rarely needed. This is something that we've not tried, but it is again something that can be considered for patients with refractory alkalosis despite doing or using other things. I hope that this talk was at least enlightening. Obviously, it involves a lot of physiology and pathophysiology. I would encourage you not just to read it, but to go back to your references in terms of renal acid handling and alkalosis and acidosis. If you have any questions, please feel free to email me anytime. I'll be more than happy to try to help clarify concepts which may not have been very well explained. Thank you so much. Assalamu alaikum.